use the right side, then that's what you have to do. But at least you're just assessing to see which one you can use.
Can they have a preference?
Yeah, and whenever I start an IV, I ask the patient, "Have you had one before? Where at?" Because pretty much they tell you they always get it here, go for it. Because if you do the opposite or something and you don't get it, they'll get upset at you. Because patients know, especially if they've always had IVs, they know where they can get the best access. So I always go based on what my patient tells me. Also for IVs, you always want to start at the hand and then work your way up. Because if you start, you can see on this mannequin how the veins are going up. And you can use the upper portion of the arm. That's fine too. So if you follow this one up and you start up here, that means you cannot use it anywhere below. So you've ruined this whole vein. So that's why they always start at the hand and work their way up. But you don't want to do the folds. I've had IVs in here and I'm just like, what? So now you can't twist because it will cause the machine to beat. So you always want to put it in a good spot. Also the anacube, you don't really want to put it in that spot unless you have to because they bend and then they got to stay straight so that the fluid flows through. Now, if they are able to be disconnected after the infusion goes in, then great, you can have it in the anacube. But it's still the bending. Also with the anacube, what artery is in this area? Brachial. So you want to assess of where the brachial artery is. Because if you feel a pulse, do not go for it. You're going for a vein. You only access veins. You do not access arteries. If you are to go through an artery, you're going to have to hold pressure for 30 minutes because it takes it a long time to stop. So even based on their anatomy, if the vein is going alongside the brachial, and you can feel the pulse and the vein at the same time, don't go for it. Because if the needle goes through the vein into the artery, you can cause an infection and some major issues. So do not go for anything that has a pulse in the anacube. All right. And their brachial artery can be anywhere. But even when you guys were learning for the blood pressure, based on the brachial artery, some people were up here, some over here. So it can be anywhere based on their anatomy. All right. These are the IV needles. These are more for paramedics because the ones in the hospital, they have another compartment back here with a little button. So when you get access, you push the button and the needle drops back so that you don't stick yourself. But this is what paramedics use. It's just something really quick and small to store. And then this is a needle. This is a 20 gauge. You always want to start an IV or gain access with the bevel up. So it's just like doing the intradermal injection, needle up, 10 to 15 degrees. So you're not going in deep, unless it is a very deep vein. So I'll pass this around so you guys can see. And then just dispose of it in the shark right there, about where Irving is. So don't stick yourselves. Now, as far as IV access, you can have them pump their fists so that the veins become more superficial. You get an IV kit. You choose your needle based on the access. And a lot of times, so if you have to give blood, what size needle can you use? 18, 16, 14. All right, so the smaller the number, the bigger the needle. If it is a fragile patient with small veins, you may want to do a 24 or 22. All right, so 20 is about midway. You can, if the patient has a 20 and it's hard to gain access, they can give blood through a 20, but they'll just give it slower. But 18 or larger is ideal. All right. So you get your IV kit, your needle. You always want to have a flush and then a connection because your needle, you need to connect some type of tubing so that it kind of extends the IV access and it's not pulling and tugging on the actual site. So you have a connection, and with your flush, you just flush your connection. So you get the fluid out, or the air out of the line. And I clamped it, so, all right. So you just flush the air out of the line. Mm-hmm. Now, this would normally have a cap on it, so you just put the cap back on it so it stays clean. But then your connection is ready, your flush is ready.
We don't have to clean the flush with alcohol or anything before you connect it?
You can clean that side with alcohol. So this was clean already because this was on it, so you would clean that with alcohol. And then you would connect. Hello. All right, so inside your kit, you have a cleansing swab. So this is the ChloraPrep. You have a tourniquet, you have tape, Tegaderm, and they give you some gauze. All right, so the tourniquet is based on if you want to use it or not. For this, if a patient presented like this, as far as like the vein access, I probably wouldn't use a tourniquet. Because when you use a tourniquet, it increases the pressure in the vein so that you can visualize it. If this was an elderly patient with thin skin, and I could see the veins, I wouldn't use a tourniquet because when you put the tourniquet on, and then you get access, it's like a balloon that pops. So it'll immediately just blow the vein, and it'll swell up. So the tourniquet is to increase the pressure of the blood in the veins so that the veins rise to the surface so that you can see them and feel them. That's the purpose of a tourniquet. But if you don't need any of that, then don't use it because it can cause the vein to blow. Rule of thumb for the placement of the tourniquet: if you're doing hand, then you put the tourniquet in the lower arm area. If you're going to access the lower arm area, then you put the tourniquet in the above the arm. If you're going above the arm, then you just go as high as you can into the armpit to put your tourniquet. So if you're going upper. All right. So with the tourniquet, as far as putting it on, you don't want to tie it like a shoelace because this is not a shoestring. So I've seen people do that. That's not what you do. Because when you get access, you want to be able to loosen this right away. It's kind of like forming a slip knot with restraints. So you just pull tight and you tell them that this is going to be tight, maybe a little uncomfortable, but you just kind of put it under like that. So then when you get access, you pop it and you're good. And then you can finish doing what you're doing. If you do the shoestring tie like you're tying a shoelace, it's not going to work for you. And you can put the tourniquet on before you actually clean. So you can put it on to find where you're going and then take the tourniquet off, get yourself set up, then put the tourniquet back on. So it's all in how you want to do it and how whatever habit you create. All right, you always want to wear gloves because you are going to be dealing with the patient's blood. So you take the ChloraPrep, whatever cleansing is in here. Sometimes it's a little pencil with a ballpoint, like just like a little small ballpoint pen. You squeeze it, and then the solution comes out. Sometimes if the patient's skin is really dirty, like if you're in the ER and they have dirt on them or whatever, and you see that on your cleansing, you can always use alcohol. Or if you don't want to use the ChloraPrep and you just want to use alcohol to clean, that's fine too. It's the same thing. It's doing the same mechanism. So you just go from a circle, about 30 seconds, you're scrubbing, and then you wait for it to dry. You want to wait for it to dry because what don't you want to cause pain, or what, I just said it, pain. Pain. Because if you get access and there's alcohol, then the alcohol goes inside and creates a burning sensation. So as far as tape here, sometimes they have bigger dressings to use, but if nurses are still kind of used to the chevron, I'll show you how they do that. Some places that just have a bigger dressing that they will use to put over the IV. All right, so let me make sure my thing's on plan. All right, so you get your IV, your angiocath, that's what it's called. And your bevel is up, and you want to tell your patient, okay, you're going to feel a small prick. And you're going to go for where you chose on the patient. So you go for an axe about 10, 15 degrees. And you see the pink, the blood that comes back? That's called a flash. You should always see that for an IV. So that means you've gotten access. When you see that, that's when you take your tourniquet off. Now, you don't ever push the entire needle into the patient's skin because they're going to say, ouch, that hurts. And you can blow through the vein. So all you do is once you get that flash, you go in just a little bit and you push this clear forward. Okay? And then, see, this is where I would have a button. I would push the button, the needle would shoot back so that I don't stick myself. You hold pressure, and this isn't going to work because it's not a real person, and you connect. You guys mind tossing it over there? Yeah, just pass it around. All right, so my flush and connection is attached. And I've undone my tourniquet. They can relax their fist. It's over with. I've gotten access. So then this is where they chevron it. So they take tape underneath. All right, and this is where I will get my big tourniquet or big tape here. And you just follow it around. And then on here you have a date and time. And you just put this anywhere along here. So now what you can do, you can pull back. Make sure that you still have access because it can't come out while you're doing all that. So you just draw back, okay, I have blood, and then you push forward. You don't, the goal is to not have any blood left in this line. Because if the blood doesn't clear out through here, then it means they can form a clot and it can stop fluid from moving forward. So you want to try to clear everything, all right? Once your flush goes through, you can disconnect. This connector here does not allow any blood to flow outward. So this stays on. You don't want to take this off. Then you can use your other tape and hold it in place. Now, this clamp is so that some people, the pressure inside their veins is strong, so it will cause blood to continually, based on a pulse, it'll just flow backwards. You don't want that, so then you could just clamp it. It'll stop that. But this does not necessarily have to be clamped. But if you see that backflow, you can do that, and it'll stop that. So you've got IV access. Now you can connect whatever you want, give whatever medication you want. All right, so now that's how we move into the primary and secondary skills. So I'll show you all of that.